Hello and welcome to those who are just joining. We'll give people a moment or two to log on and then we'll get going. So thank you very much for being here, and we're really excited for today's discussion. Hello, everyone who's joining. Welcome. My name is Lisa Koppelman. We're just going to give people another minute or two to join, and then we'll get started. We're delighted that you're here today, and we're excited for today's discussion. So for those who are just joining, again, my name is Lisa Koppelman. I'm delighted to welcome you all to today's webinar, and I think we'll get going in just one moment. So thank you all for being here, and we're really looking forward to this morning or this afternoon or this evening's discussion, depending on where you are. All right, everyone, I think we should get started. Good morning, good afternoon, good evening, depending on where you're logging on from. My name is Lisa Koppelman, and I am a program director and the team director at the Multi-Regional Clinical Trial Center. We're delighted to welcome you all here today for this webinar, the third in a 5-part series called Advancing International Pediatric Clinical Research. Today's discussion will focus on the all-important issues around assent and consent in the field, with a particular focus on culture, context, and respect. I'd like to just start off with a few housekeeping details. First, the speakers that you'll hear from today are representing their own views, not those of the agencies or the organizations that they're affiliated with. We are recording this session, and we will make those recordings available to you sometime next week, both on our MRCT Center website and our MRCT Center YouTube channel. Closed captioning is also in progress to make this more available and accessible. I just want to point to you two functions that all you as audience members have available to you. There is a chat function at the bottom of your screen. We ask that you use this for communicating with the other attendees or sharing some information. And we'd also direct you to the Q&A, the question and answer button. That is what we ask you to post your questions on once the discussions get going, as there will be a brief Q&A period following the keynote speaker and certainly part of the larger panel discussion later. So first, I'll very quickly run through the agenda. I'll provide some opening remarks. We'll then be seeing what's actually a world premiere of ICANN, the International Children's Advisory Network video. I'll tell you more about that once it's queued up to go. We'll then have a keynote address offered by Dr. Dylan Gretz and Dr. Victor Santana, who are with us today from St. Jude's Hospital in Tennessee in the USA. That will then be followed by a 75-minute moderated panel. So with that, please allow me to provide you a very brief background to get this webinar going. So Kristen, I'll ask you to start the slides, and here we go. There we go. Next slide, please. So again, I work at the MRCT Center, the Multi-Regional Clinical Trials Center, and we are a small research and policy center that sits between Brigham and Women's Hospital and Harvard University in Boston, Massachusetts. Our vision is no small lift, but to improve the integrity, the safety, and the rigor of global clinical trials. And we do this by following our mission, and that is we engage with diverse stakeholders who define emerging issues related to global clinical trials, and then we create and implement solutions that are ethical, actionable, practical, and scalable. Next slide. So with that as a backdrop, there were a series of scoping conversations that occurred several years ago, and all who were engaged with agreed that although an amazing amount of work has been done over the last 10, 20 years in advancing the clinical trial space for pediatrics, the work remains important and it remains a very difficult space to work in. I think we all agree that kids deserve access to safe and effective medications. And while kids have historically been excluded or underrepresented in research, I think we can all agree that to protect children, they really need to be included in research. So persistent ethical issues remain. There are differing or non-existent regulations country to country. Challenges remain in trial initiation and conduct. And what we heard over the course of the last year plus of very in-depth discussions is that the pediatric patient and family voice is really not routinely solicited or included in the research life cycle or in the product development life cycle. And I think at the end of the day, something that we continue to see evidence of is children are not routinely offered a seat at the table. And that's a very important reason that we engaged in this project work group and that we're engaging in this discussion today. Next slide. Thank you. So we had a leadership team for this project called, excuse me, Promoting Global Clinical Research with Children, led by a diverse leadership team of academia, EMA, industry, participant advocates. And this leadership team sort of led the charge of a stakeholder group made up of over 80 participants from a range of backgrounds from all over the world. And very broadly, we sought to identify and propose challenges having to do with the regulatory, the ethical, and the operational spaces. Next slide, please. So this webinar series today is really an offshoot of that project. As I mentioned, we're funded in part through an FDA Scientific Conference Grant Award, and we were tasked with hosting 5 virtual webinars. We host each twice, AM and PM US East Coast time, with similar content, but different speakers and panelists. And we do that to allow for wider attendance and participation, because as all of us on the call know, this work is really global in nature. And the more people we have involved in the discussion, the better we can elevate the solutions moving forward. Next slide, please. So our first webinar was hosted back in October of 2021. As I mentioned, realizing that kids are sort of late to the party, we noticed that glaringly during COVID-19. So we organized this first webinar to discuss lessons learned from COVID-19 with a particular emphasis, of course, on pediatrics. We talked about timing to initiate vaccine trials in kids. And we also talked about the infrastructure that's needed and the infrastructure that exists to quickly stand up trials. We followed this up with our second webinar back in February of this year, which focused on elevating the voice of young people in clinical research. This was a theme that we heard over and over again in the course of our year-long discussions in both the larger project work group and 3 smaller work streams that also met monthly for over a year. And so this became a real focus of our project work. Today's webinar, again, focusing on assent and consent in the field. Very nuanced, very complicated when we think about running trials across different countries with all the different details that entails. We look forward to our 4th webinar that we plan for November. Please stay tuned for details about that. This one will focus on regulatory convergence to facilitate better international cooperation with pediatric clinical trials. And then looking ahead, our 5th and final webinar will be hosted in early 2023. Before we jump into the agenda, I just want to say the amazing speakers that we'll be hearing from today, we will just quickly introduce them, but please know that we will be posting a bio book on our website, and you can hear and learn all the details about the work that they're doing. So with that, I'd like to advance the slide, and I'd like to introduce the ICANN video, Prioritizing Young People's Voices in Clinical Research. This was produced with our great collaborators and colleagues from ICANN. We are delighted to be premiering this in really an international setting. And if any of the young people involved in this or their families are on the call, a big shout out of thanks. And let's all watch this video. And again, this is a reminder of why we do this work. This is all about kids and making sure kids can access medicine in a in a cost-effective way that allows them to get the care that they need. So with that, the video. Thank you.
My first name is Abby. I'm 16 years old and I'm from the United States.
My name is Raymond. I'm 14. Uganda.
Meu nome é Theo e eu tenho 11 anos. Brasil.
My name is Jatin. I am 16 years old and I live in India.
My name is Angel. I am 11 years old. Uganda.
What do you wish your doctors had understood about you or asked you?
मेरे डॉक्टर मेरे को समझते हैं, मेरे को जानते हैं, और जो मेरे डॉक्टर मेरे को जानते हैं वही जानकारी वो अगर कभी मीटिंग होती है, सेरेमनी कुछ होता है तो मेरे डॉक्टर उसमें मेरे इनपुट्स उस कार्यक्रम में शामिल करते हैं। और मेरे को जानना है कि मेरे डॉक्टर्स मेरे को समझते हैं तो मैं डॉक्टर की अनुपस्थिति में उधर जाकर उन लोगों से पूछ सकता हूँ कि मेरे डॉक्टर मेरे बारे में पॉजिटिव कह रहे थे या नेगेटिव। तो इससे मेरे को लगता है कि मेरे डॉक्टर मेरे को जानते हैं।
I wish they understood that I like being a young researcher to be part of some important science discoveries.
Eu queria dizer que vocês fazem um ótimo trabalho com isso e que isso pode ajudar as pessoas a saberem se falta alguma coisa e se isso está sendo bom. Então, ótimo trabalho. Bom.
You know, I feel like it was more difficult talking with the doctors because when I was going to like surgery and all, it was mostly the nurses in the room. So I didn't really get that good solid connection with the doctor where they kind of asked about, you know, like maybe what activities I enjoyed or kind of gave a better relationship or just interest in kind of what was in my background and what I did outside of just the purpose of healing me. And so I think just, you know, providing that little like, I guess not patient to doctor type of relationship and just person to person to develop a strong connection.
I wish the doctors understood that the effects of clinical trials to young people. It helps the young people to express their health problems.
What are your thoughts on how decisions are made by young people and their parents or guardians to be involved or not in clinical research?
First of all, जो युवा सोचता है वह सोचता है उसका पर्सनल इंटरेस्ट होता है इसमें कि हम भाग लें, इससे हमारे जीवन पर असर पड़ेगा, इससे हम एक समझदार व्यक्ति बन सकते हैं, इससे हमारा विकास होगा और इससे हमारी नॉलेज बढ़ेगी। और जो हमारे माता पिता सोचते हैं कि वो सोचते हैं हमारा बच्चा एक समझदार इंसान बने, एक महान बने, हमारा नाम रोशन करे और वह एक और उसके जीवन में विकास हो, वो जीवन में बहुत तरक्की करे। एक अच्छी जगह पर भेजने में कभी माता पिता मना नहीं करते और वह चाहते हैं कि हमारा बच्चा अच्छी जगह जाए।
They should all be involved. Researchers must honestly involve kids in all stages of research about kids.
Bom, algo que eu acho que já devem pensar logo de cara quando convidam é que, além de isso ser bom para nós, porque vai estar ajudando a saber como de algum fator que seja importante até pra gente, isso tá ajudando médicos a saberem sobre o equipamento que criaram, se ele tá funcionando bem. Então isso é bom até para outras pessoas que não participaram da entrevista, mas que futuramente podem usar. Então eu acho que várias pessoas devem ter pensado nisso na hora de fazer. Pode ter outros fatores.
Some parents and guardians think that clinical trials are harmful to their children. They have to know that clinical trials are meant for their own benefit.
They need to just make sure that the parent feels safe and feels secure that they can allow their child to participate in this trial. I know that for me, being a teenager, that I have a different perspective on clinical trials and just I'm less fearful of them and more wanting to participate for hope in the future. But I have 3 younger siblings, and I know if I brought up, hey, would you want to participate in a clinical trial? Each one of them would have a different perspective because they're all different ages. They're 7, 10, and 14. So they're all going to have a different perspective on a clinical trial. And some are going to be more fearful, some are going to be more hopeful and more like, yeah, I want to be involved. So I think clinical researchers need to be aware of how children of different ages will respond and view clinical trials. And so I think just being aware of that is really helpful and will really be successful in the long run.
So again, a big shout out of thanks to ICANN and to all the young people and the families who supported them in being in this video. Again, it's a really nice reminder to all of us that this is why we do the work. It's all about the kids. So with that, I am delighted to pivot to a brief introduction of our keynote speakers, Dr. Dylan Gretz, Dr. Victor Santana, with us today from St. Jude's Children's Research Hospital, and here to really kick things off for what I know is going to be a great discussion. They'll have about 20 minutes or so for their keynote, followed by a brief Q&A period. So with that, welcome Dr. Gretz, welcome Dr. Santana. Thank you for doing this.
Thank you, Lisa. It's my pleasure to be with all of you today. And my goal with Dylan is to set the stage to present some issues that we need to discuss and consider, and hopefully will inform our discussion later this morning. So can I have the next slide, please? The next one, please. So when considering issues of consent and assent in resource-limited settings, some critical elements that we should always think about are how socioeconomic inequalities and cultural and linguistical differences inform how the potential participants in the research view research, and also importantly, how we approach them to participate in research. So some of the points to consider that are important factors are listed here. Let me go through them one by one because they may be points of discussion later on. So the first one is the community and leadership hierarchies that may exist. These may be different from country to country, from region to region, and even within countries, there may be different notions of hierarchies that exist in the community. And one has to appreciate those and work with those in the context of offering research to participants in those localities. The next one is the influence of gender dynamics. And this is very critical also in considering how one approaches participants in research in terms of the gender differences and how those genders may be viewed, again, culturally in different regions or in different countries. Hopefully we'll talk today a little bit about verbal consent and how that can be obtained in settings of low literacy and some of the challenges that may be associated with that. Another important one is the social status of researchers. In many of limited resource countries, researchers in terms of therapeutic research are physicians, and they're viewed as figures of authority. So one has to be careful about that potential influencing factor. The other one is guarding against therapeutic misconception. And by that, I mean that the participants need to appreciate the goals of research and the possibility that there may be no direct benefit to them. The notion of assent, which may be foreign to their society and cultural norms. And finally, one also has to consider resources. Resources could either be finite in terms of developing these processes, or they may not even exist. So one has to be cognizant of the issue of resources when one tries to operationalize these processes in resource limited countries. Can I have the next one, please? In addition, we need to think about family dynamics. And like in many settings, including Western societies and other settings, the family is a critical component in decision-making. And a family's understanding of disease is not purely medical facts, but includes spiritual and social elements. So one has to consider very carefully how these elements are important in appreciating how these participants, how these families make decisions for their participation in research. Can I have the next one, please? Now, in considering performing human subjects research, and particularly international research, the U.S. National Bioethics Advisory Committee has made important recommendations, as cited in this policy document. And many of these recommendations have a U.S. regulatory viewpoint perspective. So I think the recommendations recognize that there is a need for guidance on how to operationalize these processes and how one needs to consider real world practical details on how to implement them. And so I think that is the challenge that we face when we do international research, that there may be guidance, but how we establish and operationalize and implement that in a very real practical way remains a challenge. And I have the next one. So I bring to your attention this recent review from 2018. It's a recent publication from Marcella Collum and Peter Rohlhoff that was published in the British Medical Journal of Pediatrics Open. And what they did is they did a scoping review of cultural considerations and informed consent in pediatric research in resource-limited countries. So they, through their scoping review, they identified 50 articles that they considered worthy of providing important information. And through the review of those articles, they identified some thematic areas where guidance is needed, but also identified that there were gaps in many of those areas. And the particular gaps that they pointed to were age adaptations to consent and assent processes and how that should be documented. So this reminds us all that informed consent and assent has many parts to it. But the first part is how we share information with participants. And obviously how we share information with participants relates to communication, which leads me then to introduce my colleague, Dylan Gretz, also from St. Jude, who will now share with you a global framework for communication research in the pediatric population. So Dylan, I'm going to hand it over now to you. Thank you.
Perfect. Thanks so much, Victor. If we can have the next slide, that'd be great. So I'm going to spend a little bit of time introducing this framework, which is one that our group has used to provide what we call culturally adaptive or culturally sensitive patient-centered care. And as Victor just mentioned, communication is really at the center of this framework. And so we published this model just for further future reference earlier this year in the journal Cancer, but I'm going to take us through it step by step with some real world examples of how this model might apply to discussions around consent and assent. So next slide, please. So if we start really at the center of this model, and this model, I should say, was based off the WHO model for person-centered care, as well as a WHO model for healthcare system responsiveness. And the WHO model for person-centered care really puts the person at the center, surrounded by their family and then their cultural context within the healthcare center within a country. In our model, we've similarly mirrored the clinician's role and the various concentric circles that a clinician lies at the center of. So if we take the patient and clinician and we think about our roles in assent and consent, I think on the patient side, again, we're dealing with pediatric populations. And so one of the big questions is always how and when to involve the child. And this really varies, both whether or not parents feel that a child should be involved. Here in the United States, we don't necessarily, at least at St. Jude, give parents that choice. So we believe that all children should be involved and include them in discussions. But there are lots of settings around the world where that isn't culturally appropriate, and children may or may not be included in these discussions. And in some settings, for instance, we partner closely with a pediatric cancer center in Guatemala where the children are involved, but they're actually given a separate space to have these conversations with child psychologists. And so not only should they be involved, but when and how, and is it with their parents or is it separate? And should it be all children? And so again, particularly when we think about assent, we often think about the age of majority, and at what age do you involve a child, or do you require assent from a child or a teenager? And this again really varies. Many of our partners that we work with around the globe, there are different ages to which they treat children. So at St. Jude, sometimes you'll see patients who are in their early 20s, whereas in lots of the institutions we partner with in sub-Saharan Africa, after about 12 or 13, those patients are treated at a different hospital and considered adults. And then, on the clinician side, we think a lot about clinician time and how you build trust. In many settings, there are many more patients than there are pediatric oncologists or oncology clinicians. And so how do you establish the trust that's necessary, or have the time that's necessary to discuss something like a clinical trial in a setting where the volume is just so high? And one of the other components that we don't have time to get into today, but just to really think about how broad these issues are, is this doesn't even begin to discuss children who are orphaned or abandoned and what we do about consent in those settings when there isn't a legal guardian for those children. And so are they excluded? How do we involve them in our research? Next slide. The next level out, we mirror the patient's family with the medical team. And so in pediatrics, we know that we often talk about patient-centered care, but in pediatrics, it's really family-centered. And there's always somebody in addition to our patient. And similarly, I think, at least in my field of oncology, it's really a team sport, right? So there are many providers involved, not only in the care of these children, but in the communication and in the interactions with these families. So when I think about family dynamics, some of our work has been looking into decision-making. And so we conducted a study with our partners in Guatemala and found that similar to parents in the United States, caregivers in Guatemala, about 2/3 of them had their preferred decision-making role when it came to consent discussions around pediatric cancer treatment. Interestingly, of the 1/3 that didn't, in the US, parents often wanted a more active role than they were given, whereas in Guatemala, parents expressed wanting a more passive role and being asked to play a more active role than they wanted. So we really have to think about the culture around decision-making. and also who's involved in decision making. So we also found that mothers were significantly less likely to have their preferred decision making role than fathers, which was an interesting finding. I think we also have to think about risks and benefits as we have these conversations with families. I recently had a conversation with an international family at St. Jude around a double lumen Hickman line placement, or a Broviac central line, which I felt we needed for this patient's treatment. And in my mind, the risks of placing that central line were far outweighed by the benefits. But in this family was coming from a place where this child had had a central line, a double lumen central line, and had multiple complications. And so the risks from their perspective were really significant. And it was a very interesting and enlightening conversation for me to really think about something that, again, I don't often give quite as much thought to because it's so commonplace in my practice to put these central lines in. I think, again, on the team side, we really think about who can be involved in these consent discussions, particularly in settings where human resources are limited. So where maybe you don't have as many oncologists, is there a psychology team? Are there nurse educators? Are there even patient navigators from the community who can help be involved in some of these consent and assent, and particularly in some of the informational settings or conversations? Next slide. So going out one step from there, we talk a little bit about the resources, both the resources that a family might bring to these discussions and the resources that a clinician or clinical team could bring. And so when I think about, and Victor alluded to this, socioeconomic status and literacy, is written consent necessary or even appropriate if you have a population that either cannot read a written consent, or you don't have the written consent available in the languages that you need. And so again, actually a study that we conducted at St. Jude here in the US, we learned at some of our affiliate clinics that one of the barriers to clinical trial participation was we did not always have all of the consents necessary in the patients or families' native languages. And so, both, do you have the resources, and in settings, again, where families are coming without that level of education, without literacy, do you need a written consent? And who are you really doing that for? I think we also think a lot about the physical space in which these conversations are happening. So we're working now with a couple teams in Pakistan, and one of the teams that we're working with at Children's Hospital of Lahore has really said that they're very limited because they're having to have these conversations in rooms with many families. And so they don't have the time, but they also don't have the space to have a private conversation with one family. And everyone is listening to everybody else's conversation, which both is difficult for privacy, but it also impacts information exchange because families are getting confused as they hear other conversations that may not apply to their child or their circumstance. Next slide. And then again, the next layer out, I think about the community mirrored with the clinic or the hospital. And so Victor talked a little bit about the spiritual community, and we've seen both in predominantly Christian settings like Guatemala, as well as predominantly Muslim settings like Pakistan, that there are a lot of traditional beliefs woven in to religion, and a lot of religion and spiritual beliefs woven into, again, in our world, things like causation of cancer and what brings them to these settings, and acknowledging that, especially again in our world when it comes to things like causation, is really important to these conversations. So we've learned that you really can't or should not put aside the family's cultural context, their spiritual beliefs, but in fact call them out. And it may be that the family doesn't feel as comfortable bringing those up. And so it may be our role as clinicians to name those things for the family by saying, some families ask me about, and opening that door. Similarly, we're just starting to explore how stigma may affect these discussions, especially when we're thinking about consent to different surgical procedures. So we're looking at this in patients with osteosarcoma or retinoblastoma, where we're talking about enucleation of an eye or potentially amputation of a limb, and how stigma might affect those conversations. And again, as we think about the spiritual components that a family may bring, I think we also have to think of our broader context, thinking about our clinic or our hospital in the setting of a referral network. So again, cancer care, for instance, often takes place at large cancer centers, and we rely on folks in the community referring patients to us. And so are we connecting with our traditional healers or with some of the non-allopathic providers that patients are seeing before they get to us? Next slide. And then there's the broader cultural context. So one of the things that we've seen globally is the role of hierarchy or of deference to the medical provider. So again, in a study that we did in Guatemala, we found about 3/4 of participant caregivers, so 74%, said that they had questions that they sometimes or always did not ask their medical team. So they're holding back questions. We also saw that this idea of autonomy, which tends to be one that we think a lot about in the US, is different not only globally, but also in pediatrics. So whose autonomy? Is it the parent's autonomy? Is it the child's autonomy? And this concept of relational autonomy, but really whether autonomy should be the goal at all, or whether you can have a shared decision-making that focuses or emphasizes trust and honesty above options and making a decision between choices. Next slide. And so again, I just proposed this model, and I've taken you through the two sides of it in parallel and how each concentric circle plays a role. But I think that the most important piece of this model is actually the center, which are the interactions, because those are the places where we have an opportunity to change our practices and to intervene to make a difference for outcomes, to increase access to care or to clinical trials, to increase the quality of care, the quality of these conversations that we're having as we're obtaining assent or consent, and pertinent to our global work in oncology, decreased treatment abandonment. And so I encourage you all who are clinicians or researchers or interested in this work at whatever level to think about this model. And my hope is that it may help just really, almost like an onion, peel back the layers as we have these conversations. And I think we saw some of these layers in those children's answers to the questions in the video. And I know that we're going to hear about a lot of these layers from the panelists who are upcoming. And so my hope is just to provide this model for communication, for consent discussions that's really founded in a culturally sensitive context and with respect and dignity at the center. So I really appreciate your time. We look forward to your questions, and I'm really looking forward to the panel discussion to come. Thank you again.
Dylan and Victor, thank you so much for this fantastic foundation that you've laid for the discussion that's to come. I'd love to open it up for 5 or 6 minutes to a couple questions that some of our audience members might have, or questions you might have to one another. So people, please feel free to pose a question over these next few minutes. Or if there are additional things you wanted to add, we can take a few minutes for that.
So there is a comment in the chat or two. This positioning of all the reasons that robust consent is challenging and therefore foregone is it in important dimensions is extremely distressing. The question is, how can we improve that? The recognition is one, but then how do you operationalize what you've said? And let me read the second one. As a patient family that believes in research, I do see education as an important piece to meet these folks where they are. I'm working on ways to think outside of the box on this. And how do you think about this outside the box? Thank you.
So Barbara, this is Victor. Let me give
Yeah.
you my thoughts on the first one in terms of operationalizing some of these things, challenges. So I think one of the things that we have learned, and we can continue to learn, is that one is doing research in countries. One has to make sure that the local staff are involved in the research from the beginning. From the initial, not just come and deliver the protocol or whatever, but really make them participatory from the beginning in the whole research process. And through that, you learn very quickly of ways, you learn of the barriers and you learn from them how to overcome some of those barriers. So an example that Dylan and I have recently had is in one of our studies that we're doing, where there was a consent document and there was a survey and questions in the survey, a very standardized survey. And when we went to the sites and to the investigators and say, you know, this is the survey we proposed, they came back and said, some of these questions don't apply, don't make sense to us. They're outside of our norm, they're outside of our culture. So I think we learned, as a very small example, how when you engage them from the beginning, early on in the process, you identify these challenges. There is no doubt there are challenges, but you begin to understand how you begin to overcome them using the tools that they have, the information that they have, and the experiences that they have. So it doesn't come from a box. It really comes from their input. So that's my kind of response to that challenge.
Thank you.
And I think just to add on to that, I mean, I tend to be a fairly organized and relatively simple person. And so the model is really not to overly complicate things, but for me, it helps me operationalize some of these terms or ideas that we know from our experience. We know communication is hard. We know these consent discussions are often done inappropriately or not done at all because of the setting. And so I think we need to think about each of us, what is our role? So who am I? I am a pediatric oncologist. And so what can I do one-on-one in those family settings? So what can I do in my space, regardless of, you know, within my own constraints, within my own hospital, within my own resources, where can I find the time? How can I adjust my language? If I'm in charge of producing documents, how can I think about how those documents are written, how those documents are presented, who else is on my team? So if my time is limited, who else do I have around me that I can get to take over some of this education or meet with a family afterwards? And again, as Victor said, a lot of this we're really learning from our global partners, not just what we can do in their settings, but how they can be applied in other settings. So again, this wonderful team that I work with in Guatemala, there is a group of psychologists, social workers, and child psychologists who have really changed care in those settings by providing some of the upfront education and then meeting with families afterwards and pairing with the oncologist. So you have an oncologist and a psychologist together so that those psychologists hear everything the oncologist is saying and can then follow up with more time with those families, or can meet with the families beforehand and help the families articulate what their questions are going to be before they enter those conversations, so the families are more prepared. And again, that has worked remarkably in Guatemala to decrease abandonment rates for pediatric cancer, but we've also really been trying to study that to say, what are the core components and how can they apply in a totally different setting? And we're doing similar work right now in Pakistan and then the Philippines. So I think thinking about our own positioning, recognizing that we're just a little piece of those multiple layers of the onion, and acknowledging what the layers are and which one we want to tackle next. And so maybe in my research today, I'm going to focus on the healthcare team, but tomorrow I'm going to focus on the community and getting into that community and pairing with key informants to learn a little bit more. And I think it's at least one lifetime of work, and we're all trying every day, but that's not to deter us. It's more to inspire us. And I think conversations like this are exceptionally important, because as we each work on different pieces, we need to share those lessons, because a lot, while things are different in each culture, a lot can actually be applied. Humans around the world are much more similar than we are different. And I think learning from each other is really key.
What a great transition to hear our panel. But Thank you. Lisa.
Thank you so much for that. And I agree, that's really the perfect segue to this next portion of today's meeting, which is the moderated panel. I want to thank you both so much. What a fantastic foundation for this discussion. And I really love the thoughts around the multi-systemic approach. What is my role? What can I do? And how can we all share? And really what underpins it is teasing out the commonalities of humans, individuals, and applying it in a very person-specific way. So thank you for that. Dylan and Victor, there are one or two questions in the Q&A that perhaps you could type a response to, but I would ask for the next slide so that I can introduce the moderator and the panel. So thank you so much. I am really delighted to introduce the moderator of this discussion, Dr. Martine Dellender-Kremer. She is the Vice President of Scientific Affairs, Pediatric Subject Matter Expert, Drug Development Solutions with ICON. She has over 30 years of experience in research, in industry, global regulatory affairs, medical affairs, a particular emphasis on pediatrics. Martine is involved in any number of activities in the European Union and a variety of efforts that really touch children and their families all over the globe. And she will be opening up this panel discussion, and she will then in turn be introducing our three guest speakers, Dr. Ruben Kutika, Dr. Halima Saeed, and Dr. Mohammed Afolabi. So with that, I'd love to turn it over to Martine, and I am really looking forward to this discussion. So thank you.
Thank you. Thank you very much, Lisa, for the kind introduction. And I would like to thank everybody for joining this webinar on assent and consent, which is a very important topic. The next slide, please. And I have the great pleasure and honor to moderate this session on assent and consent with such a famous panelist from around the world who will share with you the unique experience that they have and their expertise. But before going into those details of assent and consent in the field, let me share some background information on assent and consent. Consent, that is the process by which potential trial participants are informed on all the aspects of the trial for them to make their decision. Therefore, it's really important to approach the possible trial participant and how that is done. For trials with children or minors, it is the parent or the legal guardian who has to take the decision together with the child. And whenever possible, the child has to be part and provide his assent. And when turning adult and still in the trial, then he will be consulted for consent. There is no harmonization worldwide about if it's one parent or two who will sign the consent or give the consent. There is also no harmonization in terms of assent age group. All this depends on the local jurisdictions and the local laws. The next slide, please. It's important that parents or legal guardians are not set under pressure and are given the time and space needed to reach their final decision. The information is generally given both orally and in written form to the parents and the child. And in a clear manner, it must be concise, and the language needs to be adapted. Also, the information that the child can leave the trial at any time needs to be provided. The next slide. There are cultural differences, and we will see this more and more in this webinar. And those cultural differences play a role in the process. And it is really important that We always arrange that the possible trial participant do understand the trial. So the investigator can arrange for either a translator or a cultural mediator to be available, a person that is familiar with medical terminology, but also has experience in the language, the social habit, the culture, the tradition, and the particular ethnic differences. So very important. The next slide. Consent and assent should not be only obtained prior to enrolling a child into a trial, but should be sustained during the trial. So it's important that during the visit, there is a brief discussion ongoing, there is an exchange about the information on what is new about the trial. And this is especially important for long-term trials, and to not forget also to check the evolving maturity of the child. The next slide. As mentioned, the child is to participate in this process, and he has to be treated as a person who has a potential from an early age on to express utterance and to play an active role in the decision of his life. Therefore, it's important to provide age-appropriate information, to make, for example, separate material explaining the trial, such as videos or cartoons or visuals. We need to make this child-friendly. The next slide. And when the child turns adolescent or adult, then we need to get his consent. At that time, he or she can also withdraw from the trial, and the data collected until then will then not be affected. When the child turns adult, also that depends on the local jurisdictions. The next slide. There are guidance documents. So on the NPRIMA website, you will find a guidance document on all the information regarding the legal age in the European countries, whether one or two parents have to sign. So I have put the link and you will be able to look into this here. The next slide. On the NPRIMA website, also, you will find a guidance document on how to prepare the assent form for the different age group and what to include and what to not include. The next slide. Or the next. We are, no, the previous slide. So we are in the world of decentralized clinical trials, and decentralized clinical trials have been catalyzed by the pandemic COVID-19. So when performing a survey among patients using paper and e-consent, it has revealed that patients who were provided e-consent had a better understanding of the study in respect to the proposed risks, the benefits, the schedule, their rights and responsibility. 75% had a better understanding in comparison to 58% for paper. This is an important finding that needs to be considered when planning pediatric trials in the future. E-consent is still at an early stage. It has its challenges. Regulations are not yet harmonized, but regulatory authorities are looking into this. And they are in the process of preparing guidance documents. The next slide, and before we go into the panel discussion, the next one, assent and consent follow local jurisdictions requirements. So there is no harmonization worldwide in terms of legal age group on consent and assent. There is no harmonization on the consent of one or two parents. What is important is that integrity, honesty, clarity are paramount. The investigator, the relationship between investigator, the trial participant, and the parent's legal guardian is very important. Cultural difference have to be taken into account. And this is where we still have to learn and adapt. And I hope that this webinar will help you in that respect. Also, the unknown. Will e-consent be the future? That is something we have to look into. And that said, I will hand over now to our very experienced panelists who will bring light into this. So we have Halima, Ruben, and Mohamed. I will introduce them briefly before they will share their experience. So Dr. Halima said she is a pediatric hematologist and oncologist with a special interest in pediatric oncology. She completed her medical degree from the Agent Khan University in Pakistan, her residency in pediatrics at Metro Health Medical Center in the US, and her fellowship training in pediatric hematology oncology at the Children's Hospital Medical Center in Ohio. For the last 8 years, Halima has been practicing as a consultant pediatric oncologist at Sokura Kanun Memorial Cancer Hospital and Research Center in Lahore in Pakistan. SKM is a tertiary referral center for cancer care in the region, and pediatric oncology has seen really big development in Pakistan, and Halima was part of the development of local fellowship training in pediatric oncology and the development also of national guidelines for treatment of pediatric malignancy. She is currently actively involved in the initiation of the first multi-international prospective clinical trial in pediatric oncology in Pakistan under the umbrella of Pakistan Society Pediatric Oncology. I also introduced immediately Professor Ruben Kutika, who is a pediatric rheumatologist consultant at Elizalde Children's Hospital in Buenos Aires in Argentina, and he's also principal investigator in clinical trials. He received his medical doctor degree from the University of Buenos Aires and is member of the Argentine Pediatric Association and the Argentine Rheumatology Association. After completing his residency in pediatrics, Ruben founded and developed the pediatric rheumatology in Argentina in 1974. In 1980, he was a fellow of pediatric rheumatology at the Clinical Research Center, Harrow in London. He was professor of pediatric at the University of Buenos Aires. He was also appointed as medical advisor in clinical research at Ciba-Geigy and Novartis. He has participated as principal investigator in more than 20 clinical studies for the development of drugs for rheumatic diseases. He's a member of PRINTO, and important, he is the founder and president of the Pediatric Rheumatology Foundation. And Dr. Mohamed Afolabi, he is a global health scientist and a clinical associate professor at the London School of Hygiene and Tropical Medicine. He obtained his medical degree from the University of Abidjan in Nigeria and a PhD from the London School of Hygiene and Tropical. He was awarded the postgraduate fellowship of the West African College of Physicians in Family Medicine and has a fellow from the Faculty of Public Health and Higher Education Academy. He was involved in research for vaccine for Ebola, HIV, and malaria. And he was also the one who led the Ebola pediatric vaccine trial in Sierra Leone, which led to the approval to novel dosage for Ebola vaccine for children from the AMA and WHO. He has a track record of developing innovative solutions to address unmet medical needs, such as communicating essential research information to low literacy research participants. And namely, he developed a method to deliver consent information using a locally designed multimedia tool, which integrated video, animation, and audio narrations in local language. So this is very important, and he will give you more details on this. And Mohamed also serves on several committees, including the WHO Strategic Advisory Group of experts, and also he's part of the New Field Council on Bioethics. So I hand over first to Dr. Ruben, Dr. Halima, who will give us her first presentation, and then we have Ruben and Mohamed. Halima, hand over to you.
Hello, everyone. Thank you so much for the opportunity to participate in this webinar. Please move to the next slide, please. So I'm a pediatric oncologist. I work at a cancer center in Pakistan, which is a charity hospital with a mission to provide free cancer care and as well as conduct research in oncology, both for children and adults. And I have been here for about 8 years now, working at Shaukat Khanum. And I actually loved this title when I got it, Assent and Consent in the Field, because it took me back to when I moved from the US to Pakistan. And it really did feel like like you had stepped out into the field. Like if you were a surgeon used to your own operating room and you had to go out there and perform surgery in a battlefield, because all the tools that we were so dependent on, like that conference room, the support structure, the quiet environment, that so help in communicating effectively with patients, the time to do it. Um, is not always there, and it involves a lot of improvisation and changes in your approach. And so I'm going to share a little bit of some of the issues that we face in Pakistan. Can we please move on to the next slide? So Pakistan is a developing middle income country in Southeast Asia. You can see that in red is Pakistan. It has a population of about 242 million, and 35% of these are children. So lots of kids there. There's very limited clinical trials and research that is being conducted in the pediatric population in Pakistan at this time. We do have some form of structure to make it possible. So there is a National Bioethics Committee that oversees trials, and Pakistan Medical Council that has some regulations in place and to ensure that proper assent, consent, and ethical processes are followed to conduct research. And consent by legal guardian is required for all those under 18 years of age, but there is no requirement for assent under law. And there is a very vague definition of legal guardian. Like, you know, in the previous presentation, we heard about whether it's two parents or one parent. In our situation, a lot of times it's none of the parents. It's someone else that you'll be talking to about the consent. Next slide, please. So over the next couple of minutes, I just want to just highlight some of the big challenges that I feel are unique to our culture, or you know, probably present in a lot of different cultures, but that I have faced trying to do this in Pakistan. One of the biggest things is the multitude of languages and dialects that are spoken. So there are over 60 languages. Pakistan has a huge diverse culture. It's a very rich culture with a lot of diversity, but that also brings with it lots of different dialects and languages. And the large majority of these do not have a written form. So, you know, written consent is almost an impossibility if you really wanted to be inclusive of every culture and every ethnicity that is in the country. And there's no real concept of medical interpreters in all these languages. So you're usually dependent on a family member that can translate for you, or another attendant of another patient that happens to speak the same language. And so language is a huge issue. Next slide, please. Family structure is another one. There's a lot of variation in decision makers. Again, it may not be the parents, it may be the grandparents. You may talk at length to parents and they might want to go back and consult with a grandparent or an aunt or an uncle. A lot of times the father may give consent or consent, and then the mother, once she finds out about it, may have not been taken into confidence. And so you really have to try and understand the family structure really well. And it again varies from region to region, from ethnicity to ethnicity. Next slide, please. Again, autonomy versus paternalism. So the usual attitude of our patients is a dependence on the physician for decision making. There's a lot of trust, and which increases your responsibility, obviously. And most patients will just say, you know, whatever you think is better. This may be because of a lack of education and an excessive amount of trust in the physician to make the right decision, but then it takes away from the autonomy of the patient, the child, and the parent. Next slide, please. Legal definition of a legal guardian, it's very vague. A lot of times, you know, a neighbor might even bring a child and be considered legal guardian to give permission to start treatment, but is that really ethical for a clinical trial? In a survey, even in an adult population, only 15% of the patients sign the consent themselves. Majority of the time, it may be a parent or the child in the case of elderly parents that sign the consent for procedures as well as for research. Next slide, please. And, you know, it again comes down to in a survey that was done for of people getting consent for physicians, there's a high burden of clinical work, which doesn't really leave a lot of time to do an informed consent the way it should be done. There's a lack of support in terms of data collection and management. And there's a lack of structure, place, as Dylan mentioned earlier, that at Children's Hospital Lahore, same city as me, there'll be multiple patients in the same room and no designated conference room or a consultation room where you can take patients. So it's you know, it's you really have to improvise based on where you are and try to make the best of it. Next, please. So I just, before ending and going over to the next panelist, I wanted to end on how, even with all these restraints and difficulties, you know, it is possible to make progress over time. You know, even 10 years ago, research in oncology in children in Pakistan was basically consisted of retrospective chart reviews, you know, small studies. But over time, what I've seen happen, and I've been really, really excited to be a part of, is that dedicated cancer centers have come up and fellowship training has evolved. And so sort of that critical mass of pediatric oncologists has grown in the country and eventually led to the establishment of a national society, the Pediatric Society of Pakistan Society of Pediatric Oncology, which helped to organize our efforts. And now we are on our way to initiating national level clinical trials. And we already have NBC, which is the National Bioethics Committee approval for 3 different diseases to start national trials on. And as this progresses, then a lot of other things that are being ignored, like, you know, is assent necessary? How do we define assent? Who should give consent? As research evolves, I think a lot of those things will start getting addressed and start becoming part of the legislature. So I think we're seeing a lot of progress and a lot of positive activity in this area. Next slide, please. So really to conclude, there are many, many, many practical challenges to conducting true ethical clinical research with appropriate informed consent and assent with limited resources. And these include cultural differences, language differences, complex family structures, an overly paternalistic society. And we really need to think outside the box and come up with culturally sensitive solutions to be able to address this and work as a team towards doing this. So I think that's all I had. Thank you so much for giving me the opportunity to share my experience.
Thank you. Thank you very much, Halima. And let us go through the 3 presentations before we go to question and answer. So I hand over to Reverend Katika.
Yes. Hi, everybody. Thank you very much for inviting me to this important meeting. And first slide, please. Well, I am Rubén Cutica. I am a pediatric rheumatology consultant at Pedro de Lizalde Children's Hospital in Buenos Aires, Argentina. Next, please. Next. It is a general pediatric hospital with all pediatric subspecialties, and it has facilities for phase 1 to 4 clinical trials. We have internal review board, teaching and research department, and facilities to store biological samples. So we have facilities for clinical trials. Next, please. Argentina is located very south in South America. It's very far. It's a very big country. The surface is more than 3 million square kilometers, but not so many inhabitants. We are 47 millions, and most of them living in Buenos Aires province here. This is the whole country living here, and more than 3 million living here in Buenos Aires city. And 60% of the population is from European ancestry. Next, please. 39% are younger than 24 years old, 55% is considered poor, and mostly informal employment. And at the moment, there are severe social and political struggle. And the pandemic, more than 1 year of isolation and uncertainty added fear, anxiety, and anguish to the society. So in this environment, we ask a patient and his family to participate in a clinical trial. It's not so easy. Next, please. Something that is very important is to consider the regulation of informed consent in Argentina regarding age of who should sign the informed consent and assent. In children from up to 13 years old, informed consent should be signed by the parent or one legal guardian, one of the parents or legal guardian, and the child sign informed consent, informed assent, or written or verbal, according to the level of understanding. In my case, when the child knows how to write the name, I ask the child to sign the consent, writing the name, of course, after discussing with them about the trial. From 13 to 16 years old, the patient signed informed consent. From 13 to 16, patient signed informed consent, and at least one parent or legal guardian signed assent. The regulation says in case of risk. I think this has no sense really, because research has risks. And so I think that in the group of children from 13 to 16, one of the parents or legal guardian should sign the assent. And from 16 on, the patients sign their own informed consent. And at least one of the parent or legal guardian can sign assent. But the patient over 16 is considered as an adult regarding the care of their body. Next, please. I work in rheumatology, so all my experience in research is in chronic conditions. So the patient has some time to follow up with the medical team before we ask to participate in a clinical trial. So there are a relationship between medical and patient. The first step for us is to explain what clinical research is and good clinical practice in pediatric trials. When you propose a patient or a family to participate in a clinical trial, first is they look each other because they don't understand. So I think that the important thing is to explain what is clinical research and good clinical practice in pediatric trials. We talk about a patient may be admitted to the trial. Why he can be admitted to the trial? We talk about the current treatment and the trial treatment in order that they can decide. We talk about advantages, risk, and uncertainties in research. Informed consent form is given some time in advance to read it at home. We give the form that they read with the family at home and set a new appointment to discuss about doubts and clarification, and finally to make the decision to sign or not. Next, please. The keys to successful informed consent, I think one is the knowledge about research, to know perfectly well the protocol, and to discuss all these things with the parents, with the family, and the child. We must have time and dedication to obtain the informed consent. It's necessary to have time and privacy. We take the consent form in a special office, in an office, without interruptions, to give privacy and to give the family and the patient a quiet environment. We must use clear explanations, and we are sincere and honest when explaining all the things regarding the trial and research. So I think that these are the most important keys. Of course, we first discuss the things with the child with a language that can be understood by the patient, by the young patient. And later we explain and discuss with the family and all of them in order to take a decision. Thank you very much.
Thank you, Dr. Ruben. And we have our last presentation before we go to Q&A, Dr. Mohamed Afolabi. So I give you the word.
Thank you very much, Martin. Hello, everyone, and thanks for inviting me to this exciting seminar. I hope everyone can hear me. I'm Mohamed Afolabi, as I've been introduced earlier. I'm an associate professor at the London School of Hygiene and Tropical Medicine. Can you kindly give me the next slide, please? So I want to start on a global note, how lack of appropriate and truly informed consent and assent has actually undermined the respect for the person and autonomy, and turn human being into human guinea pigs. That is what can be illustrated on the slide that you can see on the right upper part. Then looking towards the African, where I come from, and I've been living for over 3 or 4 decades, you find out that in this part of the world, illiteracy is very, very common. It is said that 1 out of 5 people cannot read and write. And 2/3 of this proportion of people who are non-literate are women. And a large concentration of this number of people who are non-literate can be found in Africa and other low-income countries, like has been described by my previous speaker in Pakistan. And closely related to lack of our inability to read and write are other group of people who are functionally illiterate. They can speak in foreign language, they could understand and converse in daily activity, but they do not have deeper understanding or meaning of technical words. So you find that they may not be able to even translate basic words in a clinical research information into what can be actioned. you ask them to sign, some of them may not be able to append their signature on an informed consent. And closely related to that level of illiteracy is poverty, diseases, ignorance, reduction in life expectancy, as well as increased crime rates. Because without high level of literacy, there will be underemployment, there will be unemployment, and also lack of access to opportunities. And it has been documented that 85% of juvenile criminals are functionally illiterate. Also, a child that is born to a non-literate mother has a 50% chance of not living beyond the 5th birthday. And in African setting, there's inadequate access to healthcare, such that the conduct of clinical trial is seen as a kind of a benefit to take care of their healthcare. So there's this kind of therapeutic misconception in which the first speaker in the keynote mentioned. Also, as described by my colleague from Pakistan, the local languages in most African countries exist in oral form, and there is no standardized writing form, making translation and back translation of informed consent to be impractical and less precise. There's also huge power differences between researchers and research participants, so that researchers are always taken as next to God. Anything they say is taken as the gospel truth. The research participant or their mother or parents do not question them, even if they have contrary opinion or if they have something that are not clear to them. It is in this context that I've just described that I've worked for over 10 to 15 years in the Gambia, in Sierra Leone, Senegal, and Nigeria, all in West Africa. And on a fateful morning in the Gambia, in my trial clinic, the mother of a young child came to my trial clinic and said that she was happy to join my clinical trial, which was about a malaria vaccine, and that she does not want to join the queue, and she's happy to join the trial because the trial was a single blind study. I wonder what she understood by single blind study. And out of curiosity, I asked her what was her understanding about single blind study. And she told me that in a single blind study, there's a possibility of losing one eye, while in a double blind study, there is a possibility of losing the two eyes. You can see the level of gross miscomprehension and misunderstanding of research concepts as demonstrated by being functionally illiterate. Please, can you give me the next slide? It was out of this scenario that the research clinician population in the Gambia, we started thinking of how to address the situation. We first of all used the African storytelling concept to tell the story by sort of interpreting instead of translating, because translation was difficult, because the language cannot be written down in a standardized format. This did not work very well. Before we also try another context-specific, subject-specific, audiovisual educational tools that we call speaking book. Speaking book consists of different pages that are well illustrated about a particular information about a clinical study. And it has a battery-powered button. And when that button is pressed, there are pre-recorded information about the information on the pages of the speaking book. And we use this in the Gambia community, and we find out that it was very, very well received, and it raised the awareness and understanding of both research participants, the parents, as well as the children about research concepts. But we also face some challenges, and we move to the next stage. Please, can you move to the next stage? Whereby we now develop a multimedia concept tool. Before going to that, the concept tool, we develop what is called audio questionnaire, because we want to actually standardize how we are going to measure the level of understanding of these participants. And this was done through what was called ACASI, that is audio computerized interactive interface or platform, whereby the participant will be assessed on the basis of understanding. Next, we develop the informed consent document of a clinical trial into a multimedia form that included video, audio, and animation. As you can see on the screen, the randomization was illustrated graphically by train of a dice. An adverse event that could not be demonstrated in a video were demonstrated through the illustration of animation, such as abdominal pain or the passage of a dark color urine. And we used the audio questionnaire that were earlier developed to assess the understanding before the participants were randomized into two groups. The first group received their information or informed consent through the traditional way of giving it through interpretation, while the second group of people received their informed consent information through the multimedia consent tool. And we also use this questionnaire to assess the understanding and the comprehension at the baseline and at subsequent visits. Our findings shows that participants in the multimedia concept group had better understanding at all the study visits, and they retained this study information about the study even more than 50 days after they have graduated out of the study. Whereas the participants in the traditional consent group had their informed consent information lost by about 50% before they graduated out of the study. This particular informed consent tool changed the way informed consent is obtained in the research center where I was working. And it was widely accepted and has been used and adapted in different settings in Africa. We published that paper in the bulletin of WHO, and it attracted a lot of international academic and research interest. So on that note, I'm going to stop so as to allow for question and answer or any clarification on the presentation I've made. Thank you very much for your attention.
Thank you very much, Mohamed, for the presentation. And now let's go to the discussion. And we have already a first question for Halima. And I invite also other speakers to put on their video. So Halima, what should be the criterion for who can give consent instead of parents? We saw that this is very specific in Pakistan. So in your opinion, what could be the criterion who can give consent?
You know, I wish I had, can everyone hear me? Because I think there were some issues with my previous mic during the presentation. Can you confirm that you guys can hear me?
We could hear you, but not so loud.
Okay, all right. So yeah, that it's actually a little bit of a dilemma for me, and which is why I mentioned it. We really cannot restrict it just to parents and grandparents, just because the way the society is set up. You know, we're living in extended families and patients, and there's only a couple of for example, in my case, oncology centers throughout the country. So people come from very, very far away with whoever has the ability to bring them to an oncology center. So at times it may even be a neighbor, or it may be a distant cousin, and most of the time they do have permission from the parents to start treatment, and that's how we get treatment consents. Whoever brings the child is considered their legal guardian, because if we didn't do that, we wouldn't be able to initiate treatment in any of these children. But what I am worried about is in terms of research, if you're enrolling them on a trial, is the same criteria okay? And I really feel it should be at least a parent, or like at least an aunt, an uncle, or a grandparent that helps give who can give consent for enrollment in a clinical trial versus a treatment consent. But the problem there would be, then we will be denying all these patients that are coming from far-flung areas that cannot provide that person for the consent process, and they would not be able to enroll on clinical trials as we get more and more opportunities for children. So those children would be denied the opportunity to be on those trials. I suppose you could do some kind of a thing where you can talk to them on the phone at least, and have a verbal consent, and have the signed consent by the person that's physically there, if they're in an area where they have access to phones or internet or WhatsApp or something along those lines, where you're sure that you are talking to a parent or a grandparent. So I think those are just some of my thoughts, but it is, even for initiating treatment, a lot of times it is a dilemma, ethical dilemma for me when I have a child with just a neighbor, it's what do you do there? And I would love other people's perspective on this.
But maybe e-consent could be in that case one possibility. You mentioned telephone.
If they had internet and the ability to read, we would have to be, most of them are not going to know English. They may be speaking a language that we would not have a written consent for. So I think e-consent, it sounds amazing, but at this point, I just don't see how we, unless we had translation or a visual e-consent, maybe, I don't know, with a video or a verbal e-consent, something along those lines. And of course, it would require for there to be a good internet connection wherever they are, or if they could at least make it to somewhere where they had access to internet. So I suppose it's an access as well as language issue in that case. But great suggestion, I think.
May I add one or two sentences to what has been said? I think in resource constrained settings, like in low and middle income countries, the internet access may not be readily available. And that is why the multimedia consent tool that I've just described to you might be relevant or appropriate, because we did it in a setting like that in the Gambia, in West Africa, and it worked perfectly well. It was not based on internet. It was based on the multimedia group. We thought outside the box, and we used the research team to sort of dramatize different parts of the clinical trial. And this was recorded, and there was a voiceover in the local languages. So we tried to look at the 3 major local languages that were widely spoken, and we did it on, and also added the animation to illustrate the part that cannot be easily dramatized and recorded. And these were put together, and we call it multimedia, and it was well accepted, and it also improved the understanding as well as the retention. So without being promoting it, I would just want to say that it's something that you can give consideration or a thought about. So because it's being used in a similar setting, and it was better than the traditional paper-based informed consent tool that we've used before.
Mark, thank you for that, Dr. Afolabi. Martine, I just wanted to jump in. and pose a question that's been put into the chat. And I've really appreciated hearing these responses, and particularly the very creative multimedia response to a lot of the challenges that you brought up, Dr. Afolabi. There's a great question in the chat that has to do with something that's we've heard a lot about in different pieces of the discussion and presentations thus far, which is about trust. So the question posed is this: is someone that runs the Alliance for Black NICU Families, a nonprofit to help families and educate? I see some similarities to our family struggles. How is trust built beyond the educational materials? So I put that out there, and I welcome Martine, you to direct that to whomever would like to respond. Thank you.
Thank you, Lisa, for bringing this to the question. So who would like to take it? Dr. Wibben?
Well, I think that there is a fact that is important, and is the consent form. Usually the consent form is written to be read by a lawyer instead of a patient. So we must explain a lot, translate a lot, because patients sometimes have difficulties to understand the informed consent form. So I think that the form should be more clear for the patient, more friendly for the patient and for their family, to be read by them, to give all the information, of course, but more easy to read, because usually the consent form is very difficult for the patients, mostly if the patient has not a level of literacy to understand. So I think that this is a very important thing that we should consider, to think about the informed consent form to make it easier for the patients and the family.
And this is a general problem, having an informed consent of 5 or 10 pages. Nobody is able or will read it and understand. Yeah, that is a global issue that we have worldwide. Dylan, you wanted to add?
Just to add on trust broadly, there are a couple interesting ideas in the literature, which I think predominantly actually come out of the US. And so I'd be interested to hear from others how they relate or apply in your settings. But there's an idea of competence-based trust versus relationship-based trust. And so the idea being that perhaps when we begin these conversations, families have some degree of trust in their clinicians based on the competence they assume their clinicians have. So if they assume that there's expertise, then they have some trust that the people providing their care are competent, which may or may not exist. And then over time, you may be able to build relationship-based trust, which is a little bit different than a competence-based trust. And I think these are really interesting ideas and ways to think about trust, both within different cultures, but particularly in cross-cultural settings. So how do we build trust across cultures? And is there always competence-based trust? Because I think sometimes it's actually just the opposite. So I don't know if that framing is helpful for these conversations around trust, but I thought I'd provide it.
My experience is with the patients is that they trust in the doctor and in the team, the research team, at the point that they says, "Oh, doctor, if you say that it's convenient for the child, we can do it." And I said, "No, I think that it's convenient, but you must be sure that it is, and you must read the consent form, and you must ask me all the questions you have, all your doubts, because usually they trust too much in the investigator. And I prefer that clarify more the things, reading the consent form and informing by themselves, and then ask the questions and discuss. But mostly, the most important for us is to explain what is clinical research. Usually when we propose to be recruited in a trial, and we say, this is a research, they look each other and they don't understand. So I think that it should be very important to have some media to explain clinical research and to explain good clinical practice in clinical research. I think that it will comfort the patient very much.
And those would be welcome everywhere. It's everywhere videos would be able to be better understood than words. I think that would be very good to have this worldwide.
This is Victor. I want to comment on the trust issue question too. And I think we have to also understand that consent and assent, although they may occur in one period of time, is not only a one-time event, but it's an ongoing conversation during the whole participation. And when Dylan was talking about relational, it reminded me, right, that that's part of building that relationship, that conversation occurs multiple times. And that's a key to building that trust, right? Mm-hmm. You may have to redirect what you're doing, rediscuss what's happening, and remind them again that they have an option if they wish not to continue to participate to do so. So I think understanding that consent and assent are not static events, but are dynamic events helps build that trust and that relationship. And saying that to patients and to participants and to parents, I think is critical too in building that trust.
Martine, this is Lisa. I just wanted to follow on to to the comments that Victor added, because I think we all agree, as you rightly point out, it is a process and trust develops over time with the demonstration that there's respect and humility and a curiosity to understand the individuals that we're communicating with. And just as an offshoot, there are a number of questions around assent. And I just wanted to pose this, and Martine, if you would like to direct whomever or ask whomever to answer, but what do people think about the requirement for assent? Of course, of appropriately aged and mature young people. Is assent something that should be required across the globe, or is it something that should perhaps be more of a local decision? I think that this is a very nuanced issue that's very difficult to land on, but I think bringing out the issues from different perspectives could be quite helpful. So I'll leave that to this group.
Thank you very much, Lisa. I would like to have the opinion of Dr. Muhammad and Halima for this, because they are in a situation where it's not yet really set in stone. So what would be your opinion in the countries where you still have to set more things and regulate further? So what would you like to see?
So obviously, ideally, I would like to see assent be a part of what's required. Yes. But where we are at this point, it would really limit what we're able to do. I think if it was a legal requirement to have assent, because it's very difficult to convince parents to actually let the child be involved in the decision making, even in the treatment. A lot of times, because again, about the language barriers that I talked about, some of the parents are able to understand other, Urdu or English, whichever is the language that we're communicating in, but the children are not, because they've just been educated in their local language. And even though you keep asking the parent to translate for the child or the legal guardian, whoever is with the child, you can tell that they're really not conveying each and everything to them. And you can tell that from sort of how the child is responding to what you're saying. When you're delivering bad news and the child looks really happy, obviously what was said in the translation is probably not authentic. So I think eventually in the, if you're able to have standardized Assent and tools that help us communicate more effectively with children at their level, and they can truly give Assent, that would be the ideal situation. But I don't think we're there now. So at this point, even if we can get good informed consent and actually be able to get the point across to the parent or the legal guardian and get a correct decision from them, I think that would at least increase the number of children that we're able to enroll in trials. I think making Assent a legal requirement at this point would limit the number of children that we're able to enroll. Those are just my thoughts with where we are at currently. What do you think, Mohammed?
Yes, thank you very much. I totally agree with you, Dr. Alima Saeed. In most African settings where I've worked, Assent is a legal requirement, but the age of Assent varies from country to country. Whereas in some countries, Assent starts from the age of 7 years, and in other countries, it's from the age of 12 years. And in clinical interventional trial, Assent is a must, and it has to be written Assent. Whereas in observational trial with low risk to the participant, a verbal Assent is accepted. So, and there are usually the ethical committees and the regulatory bodies who do not take it lightly that these are not reported or captured appropriately. So in most of the settings where I've worked in Africa, this is what happens. But how do you ensure that Assent is done in a way that the children will understand it? Is one of the challenges that keep coming or staring us in the face. We have used speaking book. Speaking book is able to ensure that the children is able to go through the information in an understandable way, but it cannot replace that human interface involving trust building and ensuring that a truly Assent is obtained from a child that is not up to the legal age of consent. That's a kind of a work in progress in most of the African settings.
Thank you both.
I wonder if I could ask a question, which is, there's a significant difference between clinical trials, interventional, minimal risk, and those where that's necessary for the treatment. We've heard about pediatric oncology, where clinical trials is really part of the care, versus one where it's not required for care, it's elective. And, the question of Assent and then dissent, I think, is quite different in those settings. I wonder how you think about them. So how is that considered?
If I may start from in most African setting we have worked, this cut across established research center like a Medical Research Council in the Gambia, and as well as the similar sites across part of East Africa in Uganda, and also MRC in South Africa. There are usually some sort of guidelines that are based on or adapted from the internationally acceptable ICA GCP. These are adapted into the local context, and they try to implement it. And there are usually bodies which tends to regulate and ensure compliance with this. Because I've seen trials which have been shut down because of non-compliance with the ethical guideline of Assent in clinical research involving children. So it's always taken very seriously in most of the settings that I've known in Africa. So that is what I've seen in part of where I've worked so far. In other settings where the clinical trials involve intervention or a situation whereby it does not involve care, so then another kettle of fish or another kettle of another dimension or perspective will be involved. It will not be, they will not be reporting to a kind of a central ethical bodies or regulatory authorities. They may be having some internal hospital ethical review boards, and they also always want to ensure that the standard practice is followed. I do not have much experience in that aspect, but I know most of the time they tend to follow the internationally acceptable guidelines.
Mhm.
I suppose my question is, are there internationally acceptable guidelines? That's the problem. Is there doesn't seem to be any established guidelines for Assent. Are there, like, that you would say can be applied across the world?
What I meant, I'm aware of some of these efforts that have been done by Norfolk Council on Bioethics based in the UK. They commissioned a report on clinical and pediatric guideline and how to obtain consent and assent. I have access to that report. I'm happy to share with you. They outline some of the guidelines that could be used for global clinical research and can be adapted to context in which you are working. That is available. And I was also part of the people that they were interviewed to form that report. So I'm aware, and I've also put this into practice. So I can talk about how we obtain assent in malaria vaccine, and also how we are malaria vaccine trial, and also in Ebola vaccine trial in Sierra Leone, especially when participation in clinical trial was driven by fear of catching Ebola then, when it was very, very endemic in that part of the country. So, but we were able to navigate all the challenges through implementation of those guidelines and also contextualizing it to the setting where we were conducting the clinical trial.
Mhm.
So I'm happy to avail to make to share those reports for anybody who is interested, because there might not be many guidelines, but there are some limited guidelines that can be used, can be developed further, and can be adapted and contextualized as the case may be.
That would be very helpful. If you send them to us, we'll make them available on the website.
I will send it. I'll send it
Yeah.
to Lisa and Martin
That's
at the end
great.
of this session.
And you know, there's also the Nuffield Bioethics Council that did a wonderful report a couple of years ago. But they are all our guidelines. There's nothing, you know, E11 has some direction about what's expected. I don't know whether Pakistan is an ICH country, but there's that. And then SIOMS has good guidance also, but again, it's guidance. And, you know, given what we've heard today in terms of the international complexity, I'm not sure that an international regulation is, at least at this time, the right answer. We have to meet people where they are.
I'm not aware of that. And the document I was actually referring to was the work commissioned by the Norfolk Council on Bioethics, the one that I said I'm happy to share. So, and that is where we obtain some of the guidelines that we implemented in the field when we were faced with the challenges and the dilemma of obtaining assent from children.
Yes, actually, the consent is requested from a regulatory standpoint, but not the assent. The assent is not a regulation. Yeah. In no country, it is a regulation. Yeah.
In low, you mean like in low income country or low and middle income countries?
No. What I mean is that assent is not part of a law. Yeah, the
Okay.
consent is required by law.
By law, okay, okay.
And it is the ethic committee's guidelines who request the assent. Yeah.
Thank you very much, Barbara. Barbara has shared the document on that was commissioned by the Norfolk Council on Bioethics, and there are some a lot of guidelines that were reported based on the interaction and the feedback they got from researchers from the field. So, and I happen to be one of those people that were interviewed on what practical implementation of what we are doing, how we are obtaining consent and assent in pediatric research across low and middle income countries.
That's indeed a very important document. Yeah.
Yes.
Yes.
So I am mindful that we are coming to the top of the hour, and I do want to be respectful of people's times. I think we can move to the very end of the slides and to say thank you to everyone. Martine, if you just want to take literally one moment to wrap up what has been an extremely interesting and valuable discussion. And then Barbara, if you just would like to take 2-3 minutes to kind of close out the session, it would be very much appreciated. So if you can just scroll through to the last slide very quickly, Kristen, and then a special thanks to everyone who has participated in this, all the speakers, etc. Martine, over to you for just a moment, and then Barbara, thank you. We can go off slides, thanks.
Okay. Thank you, Lisa. So I wish to thank everybody for the contribution, also the panelists and all the people, the audience. We heard from the expert how important it is regarding assent and consent worldwide, and all the nuances and the cultural difference. So without assent and consent, no pediatric trials can be conducted. Therefore, it is paramount for pediatric research. And we saw that it's really complex and there is no one solution for all. Local cultural and traditions need to be taken into account. And if we want to be successful, we have to find ways to ensure that every solution identified allows to meet regulatory and ethic requirements. So I want to thank everybody for the participation and the lively discussion and the very interesting questions. So I hand over to Barbara, but thank you, Dr. Halem, thank you, Dr. Rubin, and thank you, Dr. Mohamed, and thank you to the audience. And I also want to thank MRCT for organizing this webinar. Thank you very much.
Thank you. And I want to add my thanks. I want to say that there, one of the things that's impressive is there are certain countries that have, assent regulations like the US, tri-council policy in Canada. India has its regulations, but it's not, but it's not, as we've heard today, an internationally accepted requirement, even if it is a seemingly ethical, of ethical importance to have the understanding, if not the assent of children that are involved in research. And I think that is probably the most complicated question here, is who can consent and how much are we sort of availing ourselves of our expertise in deciding what is or is not appropriate for the child and the family. And I think what we've heard is there are frameworks, one of which we heard about today, to help us think through all of the different aspects that need to be considered in framing the answer that is both locally, culturally, spiritually, and value concordant for the patient and their family. I think this is a fascinating conversation that you all have done such a great job of illuminating for us, and we look forward to continuing it. We'll have another different panel, same topic tomorrow, in order to hear from additional folks about what those challenges in the field is or are, and how the different aspects that we can approach this to answer it. You know, one of the things I think that is clear is that communication is core.
Yes.
And health literacy and meeting people where they are in the language and in the spirit in which they come to us is critically important and a foundation of trust. And with that, I want to really thank everybody dedicating their time here, and just a wonderful conversation. Thank you so much.
Thank you.
Thank you
for
to
having us.
everybody.
Thank you.
Thank you very
Thank
much.
you. Thanks, everyone.
Thank
Fantastic
you.
discussion.
Bye.
Bye, everybody.
Bye-bye.
Now,
we still have just a couple of attendees still on.
yep,
So I'm just going to take some screenshots of the chat.
that's fantastic, and we'll capture the residual questions, and perhaps we can stay on for just a moment.
That would be great.
You can turn the recording off.
Oh, that's true.